Okay, so firstly, we're going to start with Rhoda Akilapa, and she's a consultant in clinical genetics at Guy's and St Thomas's. She specialises in rare diseases with a particular expertise in skeletal dysplasias and connective tissue disorders. So Rhoda leads specialist clinics at the Evelina London Children's Hospital, including achondroplasia, skeletal dysplasia, and cleidocranial dysplasia services. Have I said that right? Yeah. She also runs a diagnostic connective tissues disorder clinic at Guy's Hospital, supporting both children and adults with conditions such as Marfan syndrome, vascular Ehlers-Danlos syndromes, Loeys-Dietz syndrome, and other related disorders. In addition to her specialist work, Rhoda sees patients of all ages in her general genetics clinic, including those requiring prenatal counselling and families affected by the loss of a child or a relative from a suspected genetic disorder. She's an active member of the genetics community and serves on the Council of the Skeletal Dysplasia Group, and she's also a member of the International Skeletal Dysplasia Society and VASCERN, the European reference network focused on rare vascular diseases and cardiovascular genetic conditions. And we are also delighted that she's going to become a trustee of the Ciliopathy Alliance as of our AGM in a few weeks' time. So without further ado, I shall pass you over to Rhoda, who is going to tell us about really the importance of why we should get diagnosed as early as possible with ciliopathies. So,
Brilliant. Thank you.
okay, you're doing good. That's great. Thank you. Yeah,
Fantastic. And can you see my screen?
I can. Yeah, thank you very much. I
Okay.
will mute myself.
Okay, so thank you and welcome everybody. I can't see sort of people, but I'm delighted to be invited to talk about skeletal ciliopathies. As Fiona has already mentioned, I'm based at the Guy's and St Thomas's Trust, and a lot of my work is at the Evelina Children's Hospital, where we see children with lots of different types of skeletal dysplasias, including skeletal ciliopathies. So what I wanted to start off by doing is just talk a little bit about sort of skeletal dysplasias in general, and then focus in on the skeletal ciliopathies and the importance of those conditions. So when we think about skeletal dysplasias individually, these are very rare genetic disorders, but collectively they're not as rare as one might think. So the birth incidence of having a child with any skeletal dysplasia is about 1 in 5,000. And that can be comparable to, say, the instance of a young person being diagnosed with diabetes type 1. So when you think of them as a collective group, it isn't as sort of rare as one might think. And historically, back in the days, we used to kind of lump children into two groups. So if they had a short trunk, they were sort of more Morquio syndrome. And if they had short limbs, we would say, you know, sort of a form of achondroplasia. But over time, now that we have access to much more advanced genetic testing and understanding of the mechanisms that cause these conditions and the radiological changes, the number of skeletal dysplasias has exploded. And then, of course, when we're thinking about ciliopathies, we know that ciliopathies itself is a huge group of disorders caused by abnormal ciliogenesis and intraciliary transport. And then the skeletal ciliopathies are a subset of ciliopathies that mainly affect the skeleton. So, of course, we know that many ciliopathies have some skeletal features. If we're thinking of, say, for instance, Bardet-Biedl syndrome with the polydactyly, but when we're thinking of skeletal ciliopathies, we're thinking of conditions that the main features is really the skeleton primarily. So this family of disorders includes conditions such as Jones syndrome, Ellis-Van Creveld syndrome, Sensenbrenner syndrome, and lots of other conditions as well that fall into groups such as the short-rib polydactyly syndromes as well. So I would say that Jones syndrome and Ellis-Van Creveld are probably two of the most well-known skeletal ciliopathies. And the common clinical features we tend to see in these conditions are the thoracic hyperplasia. So that short chest that really is the problematic thing that leads to respiratory failure in the young babies born with these conditions. Short limbs as well is one of the key features, and very significant shortening of the fingers and polydactyly. So significant findings we see in the hands. These children, although the primary features that they have is the skeleton. They also have the extraskeletal findings as well. So many of the children that we see with skeletal ciliopathies also can develop renal disease, liver fibrosis. Many of them have ectodermal dysplasia features as part of their condition, and congenital heart disease, particularly thinking of Ellis Van Creveld syndrome. So it's still a multi-system condition. Next slide. Oh. Oh, there we go. So just thinking about again how we are dividing up these skeletal ciliopathies. Over the years, there's been different sort of nosologies or namings of these different types of skeletal dysplasias. And the most recent sort of iteration of that is the ISDS nosology that was revised in 2023. And so at the last count, there are now 771 different types of skeletal dysplasias in total, caused by pathogenic variants in more than 500 genes, and these have been divided into 41 different groups. So the skeletal ciliopathies amongst the skeletal dysplasias are group 10. So we see group 10 here. And there are quite a large number of them. They are all tend to be autosomal recessive conditions. And then the paper sort of talks about the gene as well. So the nosology has changed quite drastically over the last few years, I would say. And I think that the naming has now moved much more towards gene related rather than naming a condition after the doctor or professor who first described that case series, or naming a condition just based on the clinical features that we see. Over time, as we've begun to understand the molecular mechanisms behind these conditions and the causative genes, naming has sort of shifted more towards, what gene is related to this particular condition. So again, this is just continuing with the nosology. We see, all the way up to number 24 of the skeletal ciliopathies, all the way to number 43, and then the last slide showing all the way up to number 61. So at the moment, at last count, there are 61 different skeletal ciliopathies. So again, it's quite a big group of conditions. One of the things that was highlighted in the nosology in 2023 is that they're preferring now to use the term short rib thoracic dysplasia rather than asphyxiating thoracic dysplasia. So for Jeune syndrome, historically it was known as asphyxiating thoracic dysplasia. But of course, the term asphyxiating, I think for lots of people, it had a negative connotation. It's also quite inaccurate. And I've certainly heard stories of families who, one of my colleagues was looking after a family where the mum had come to a follow-up clinic. Her child was about 2.5, and she sort of said, when is it going to happen? And they said, well, what are you talking about? And she said, well, when is my baby going to asphyxiate? Because, that's what it's called. And it's as if she'd been waiting for this child to asphyxiate because this was the name given to the condition. So I think a lot of people welcome moving away from that terminology, using that term asphyxiating. So since we've sort of started with Jeune, this is the first condition that I'm going to talk a little bit more about. So this is a condition that is quite rare, with a reported incidence of about 1 in 100,000 to 1 in 130,000 live births. The main features we tend to see clinically is that babies are born with sort of a long, narrow thorax, and of course that can lead to respiratory difficulties in infancy. So if babies are able to survive that kind of stormy neonatal course and come through the neonatal unit, as they get older and their chest grow, they start to get normalization of the thoracic function later on in childhood. They also present with short extremities, so short limbs, and particularly with short hands and feet as well. Sometimes with Jeune, you do get postaxial polydactyly, so extra fingers, sometimes extra toes, not always. Certainly, a family that we see in our clinic that I can think of, both siblings were actually born with extra fingers and extra toes. And then later on in childhood, children can suffer from progressive renal disease as well, and hepatic fibrosis. Less commonly, some other extraskeletal features can be seen. So Hirschsprung disease, multiple gingival frenula, and mild hydrocephaly is seen much less commonly in this condition. So in terms at the time that it can be diagnosed, with Jeune, this is something that is often diagnosed antenatally because the features can be seen on an antenatal ultrasound scan. Of course, at birth, babies, you can clearly see this very small thorax, short extremities, and the short hands and feet. But antenatally, if a scan has been done, often you do see these features before birth as well. And then later on in childhood, there are some milder forms of the condition. Maybe the pathogenic variant in the gene might be sort of an attenuated type of mutation that that child has. You can get children who are diagnosed a little bit later, where they're being diagnosed with short stature or renal disease, but it's much more commonly diagnosed very early in life or antenatal. In terms of the radiological features that we see in Journe syndrome, of course, the small thorax is one of the most striking features that we see, and that's a small thorax in both the transverse and the anterior posterior diameter. Also, the ribs are quite horizontal, and you do get irregular costochondral junctions as well. The iliac bones are quite short, and you get these spur-like downward projections. It's quite difficult to see here, but you sort of get a spur here, a spur here, and a spur here, and it's described as a trident pelvis. So just thinking about kind of a three-pronged fork, and you do see this sign in some other skeletal dysplasias as well, but certainly in the skeletal ciliopathies, it's one of them that you see this kind of trident pelvis configuration, which helps radiologists make this diagnosis. And other radiological features, you also get premature ossification of the capital femoral epiphysis. I think this baby's too young to see it here. You get disproportionately short limbs and irregularity of the metaphysis. So here, sort of the end of the long bones, there's some irregularity you can see here. You get cone-shaped epiphyses, which are features that can be seen in the fingers. Obviously, this picture's too small to see that. And then, as I said, sometimes children are also born with the postaxial polydactyly with Journe as well. So this baby does have an extra finger there and an extra finger there. So this baby does have postaxial polydactyly. And then in terms of a genetic diagnosis, if there are features of a skeletal ciliopathy seen antenatally, then invasive testing can be done usually on a chorionic villus sampling, which can be done from around 12 weeks gestation, or if it's picked up later on at a 20-week scan, often it's an amniocentesis that can be done where they take some fluid, amniotic fluid from around baby to do the genetic test. And it's not a single gene that causes Journe, so there are a number of different genes that can be implicated in the condition. It is autosomal recessive, like most of the ciliopathies. So, of course, each parent is often a carrier of the condition. And it can be caused by genes that are encoding the intraflagellar transport protein, so the IFT genes, components of the retrograde IFT motor complex dynein 2, so this DYNC2H1 gene, some of the WDR genes as well. And then also the genes that encode proteins that are involved in centromere formation and modification. So the most common gene that's implicated in Journe syndrome is this DYNC2H1 gene. And then the sort of second most common is the WDR34 gene. So in terms of the natural history of what we see in Journe syndrome, of course, those children that are born with a very small chest, the respiratory distress tends to be the most severe complication, and that's what really accounts for the increased mortality that we see very early on in life. However, nowadays there is a lot of advancement in neonatal care, and over the years, of course, that's led to improved prognosis and survival in children. For those children who are able to overcome and kind of survive that neonatal period, children that we see who are surviving sort of into that childhood school age and sort of toddler age, they do struggle sometimes with recurrent respiratory infection. So they're often under the respiratory team, often might need prophylactic antibiotics and have a low threshold to sort of treat respiratory infections. As children grow bigger and their chests grow bigger, their respiratory problems tend to improve over time. But then as they get older, then you do tend to see a bit more of the extra skeletal complications as well. So the progressive renal disease can happen sort of beginning in childhood. Some children can develop portal liver fibrosis as well. In the medical literature, it reports about 20% of survivors being seen to have the sort of liver and renal complications. But the older this cohort of children get, and the longer they survive, the higher proportion tend to develop some of the extra skeletal complications that we might see in the other ciliopathies. So I suppose the other thing about the underlying genetic cause of Journe is the most common gene that's implicated, which is the DYNC2H1 gene. those children tend to have more of a skeletal phenotype, so struggle more in the antenatal, sorry, in the perinatal period with the breathing, the postnatal period, and they don't tend to have as many as the non-skeletal features. Whereas the intraflagellar transport genes, they tend to get a milder skeletal phenotype, but more severe of the non-skeletal complications. But in general, there isn't very strong sort of genotype phenotype correlation. So that's just kind of a general trend that we see with those two particular genes. And the final adult height of children with Jones syndrome that do survive a little bit more longer term is within kind of the lower range of normal. So they are not very short, but usually shorter than siblings and other people in their family. And then in terms of treatment, of course, this is multidisciplinary care. So in the early stages, it's very much the neonatal team and it's that sort of respiratory, cardiorespiratory support. Ophthalmology, hepatobiliary and renal become much more important later on. And of course, therapy input as well as children are sort of starting school and going into educational settings, making sure that they have any adaptations that they might need, particularly with the shortness of the fingers. And if they have recurrent chest infections, whether they're needing any sort of medications to be present at school. I guess again with the early neonatal period where things can be more severe, one treatment that has been explored is surgery for chest expansion. So VEPRT stands for vertical expandable prosthetic titanium rib. So this is an implant that clever surgeons can put in to try and make the chest bigger to buy time to get baby over that sort of very difficult early neonatal period. But in terms of how well that works, from the reports that I could find, it kind of improves survival by maybe 5 to 10%. So not massive. I think that if it's very severe, it's very severe, really. Now, moving on to one of the other more well-known types of skeletal ciliopathies, this is Ellis Van Creveld syndrome. So this is a bit more common with an incidence of 1 in 60,000 live births, and it's also known as chondroectodermal dysplasia as well, because of the ectodermal features that we see with this condition as well. So in terms of the features that we see when we come across children with Ellis Van Creveld syndrome, they do have disproportionate short limb, short stature, and the shortening sort of progresses as you go down. So particularly when you're looking at X-rays, you can see that the tubular bones get shorter as you go more distally. There's postaxial polydactyly of the fingers, usually with Ellis Van Creveld, and sometimes the toes as well. This little girl has postaxial polydactyly of her fingers. And the hyperplastic nails, so the nails are quite dystrophic, which you can see in this child, and genu valgus. So of course she has that as well. This is just another example of two siblings with Ellis Van Creveld syndrome. You can see that they also have postaxial polydactyly and the genu valgus. Okay. Other features that we see in Ellis Van Creveld include the sort of the facial and the dental abnormalities as well. So the upper lip is often quite short and you see multiple frenulae, which actually you can't really see in this picture, but the kind of fleshy connection within the kind of mucosa of it within the mouth. Then the dental anomalies can be quite striking in Ellis Van Creveld syndrome. So some babies are born with neonatal teeth. Uh, Children often have hypodontia or oligodontia, so some missing teeth, small teeth, so microdontia, peg-shaped teeth. They can have malocclusion and enamel hyperplasia as well. So it's very important for them to be under a specialist dentist. Up to 60% of children with Ellis Van Creveld syndrome are born with a cardiac congenital heart disease, so a cardiac defect. And occasionally they can be born with a small chest as well. So there's a lot of overlap with these conditions. In terms of the time of presentation for Ellis Van Creveld, it's usually very evident at birth because you can see when baby's born, they have short limbs, they have polydactyly, and often the cardiac anomalies can be picked up at birth or before birth. So, of course, in antenatal scanning, many of these features can be seen on an antenatal scan, and it has been diagnosed from sort of 15 weeks gestation. So it can be seen fairly early on during a pregnancy. And then in terms of the radiological findings, of course, you can see here, you can see the postaxial polydactyly, but you also tend to get fusion of the metacarpals. So here you see that the fifth metacarpal bone is fused to this additional digit here, and the same on the other side. You also, again, get premature ossification of the capital femoral epiphyses, and sometimes you do get that small chest that can lead to respiratory difficulties early on. Again, similar to Jeune, you get the progressive shortening of the tubular bones, the more distal you go, and short sort of fingers, so phalanges, and with Ellis Van Creveld, the hyperplastic distal phalanx. So the very, very tips of the fingers are the smallest. By the time children move into childhood, on radiographs, you can see that many of the changes in the pelvis and the thorax that we saw when they were babies tends to normalize. And then you see the cone-shaped epiphyses. So these sort of changes that you can see in the fingers. Unfortunately, this is an X-ray of the leg, so we can't see that here, but you can see progressive coxa as children with Ellis Van Creveld syndrome get older. In terms of genetics, again, it's autosomal recessive, as most of the ciliopathies, and with variable expression. So some children do have many more features of the condition, whereas others it might present more mildly, even amongst siblings within the same family. And the genes that are responsible is usually the EVC or the EVC2 gene, and these are encoding for proteins that are important for normal response to hedgehog ligands. Other genes can also cause Ellis Van Creveld syndrome as well, a bit less commonly, but certainly the inflagellar transport genes and some of the WDR genes as well can cause an Ellis Van Creveld phenotype. So in terms of the natural history, again, it's really the respiratory, so the lungs and the heart complications that contribute to the more severe side of things where babies don't survive, and that's thankfully less common in Ellis Van Creveld syndrome. Dental problems tend to be quite significant in Ellis Van Creveld syndrome, and children can lose teeth prematurely. They have malalignment and caries, so frequently need dental input. With genu valgus as well, this is something that develops and can affect gait, and so often children will need referral to an orthopedic surgeon to sort of think about treatment for that. And then occasionally, if there is a small chest, you can get these recurrent respiratory tract infections in childhood as well. But if you don't have significant heart and lung problems, if you don't have the cardiopulmonary complications, then the lifespan in Ellis Van Creveld syndrome is usually normal. Then in terms of treatments, what we'd already talked about, there needs to be, again, multidisciplinary team involvement. So cardiologist is very important in Ellis Van Creveld syndrome, with more than 60% being born with a congenital heart defect. Respiratory team may need to be involved if there is a small chest, and if there are, recurrent chest infections or difficulties with breathing early on. Dental input, as we've already talked about, is very important. And then also involvement with plastics and orthopedics because of the polydactyly, but also orthopedics because of the genu valgum that we tend to see. And then, of course, therapy teams is very important as well. So children starting school, going into an educational setting, it's quite important for them to have input from physiotherapy and particularly occupational therapy as well, thinking about aids that might help for sort of thick finger grip with the brachydactyly and those sorts of things. Moving on to the short rib polydactyly syndrome. So this is a heterogeneous group of conditions, and there are a number of different genes that can cause different types of short rib polydactyly syndromes, as we've seen from the nosology. This is on the more severe end of the spectrum again, and clinically you often see this hydropic appearance at birth. The limbs can be very short, and you see the postaxial polydactyly and brachydactyly, so shortness of the fingers, the extra finger as well, a narrow thorax, and you get the protuberant abdomen. Extraskeletal features can also be seen with the short rib polydactyly syndromes as well, so cardiovascular anomalies, renal hyperplasia, you might see renal cysts on scanning, pancreatic fibrosis, you can also see pancreatic cysts as well, and genitourinary anomalies, so you can get uterine anomalies as well. Less commonly, it has been reported in short polydactyly syndromes for there to be abnormalities of the brain, so cerebellar hyperplasia or Dandy-Walker malformation that's been seen less commonly. So in terms of when this can present, often it is seen antenatally. So you see all of these features usually, at least from 15 weeks gestation. And it's usually perinatal lethal because of the severity of how small the chest is. So just looking at the radiographs, you can see quite strikingly short horizontal ribs So this is going to lead to pulmonary hypoplasia and significant respiratory distress. You get the small iliac bones as well with the flattening of the acetabular root, and you can see this kind of trident appearance with this being kind of a point here, this point, and this point here. So this spikiness of the iliac bones causing that trident pelvis. You can get incomplete ossification of the short bones, so you can almost see these kind of raggedy edges of the bones here, here, and here, and the postaxial polydactyly. So you can't see the hands on this X-ray, but often these babies have additional digits on the hands and sometimes feet as well. So again, autosomal recessive and genetically heterogeneous. So the WDR genes, the DYNC2H1 genes. So it isn't sort of a single gene that causes this condition. And in terms of the natural history, this is a severe condition. So often it is perinatal lethal, mainly because of how small the chest is. Moving on to cranioectodermal dysplasia. So this used to be called Sensenbrenner syndrome or Levin syndrome. This is a skeletal ciliopathy where one of the features that help make the diagnosis is the shape of the head. So dolichocephaly, which you sometimes also get with a craniosynostosis. So the sagittal suture is sort of fused, causing this kind of narrow shaped head if he was kind of facing forwards. You get the high forehead as well, and so sort of distinctive facial features, so epicanthic folds and full cheeks with an inverted lower lip. And children often have sparse, slow-growing fine hair, so there's these kind of ectodermal changes, hypohidrosis, and so sort of not able to sweat as one normally would. Again, hypodontia, so missing teeth, oligodontia, small, widely spaced teeth as well. So many sort of overlap and similarities with Ellis Van Creveld syndrome. They often have short limbs and narrow thorax, often with pectus excavatum, which you can see in this little boy here. In terms of the presentation, again, many of these features you can see at birth, and also antenatally, if there are short limbs, it's something that sometimes can be picked up in the antenatal period as well. So looking at the X-rays, we talked about the dolichocephaly, so the shape of the head, and sagittal synostosis, the short long bones, and you can see a bit of mild metaphyseal flaring, so the ends of the bones kind of widening just a little bit there. Often you can see bowing of the humeri, so the bones in the upper arm there are slightly bowed, and certainly you can see the bowing of the bones in the lower limb here. And you get short middle and distal phalanges of the hands with cone-shaped epiphyses in the distal phalanges. I'm sorry, I don't have an X-ray of close-up of the hand to show that. But you do get sort of a narrow chest, not anywhere near what we've seen with the short-rib polydactyles, but sort of relatively narrow with the pectus excavatum that we saw, and osteopenia as well. So sometimes the bones will be softer than you might expect them to be. Again, autosomal recessive and very heterogeneous, mainly the intraflagellar transport genes. Many of them can cause cranioectodermal dysplasia. In terms of the natural history, this is not a condition that affects intelligence, and so children have normal cognitive functioning. Final light is often in the lower range of normal, sometimes a little bit below that. And again, the mortality is really due to those children who have more of the heart and lung difficulties, which is thankfully, again, less common with the cranioectodermal dysplasias than in some of the more severe ones we talked about. But renal failure later on in childhood can become a problem, and some children do develop nephropathy in early childhood. In terms of treatment, so these children often need to be referred to sort of craniofacial teams if there is craniosynostosis that needs to be repaired. Any sort of infections or renal disease needs to be kind of treated. So again, multidisciplinary care, the same for all of our children with skeletal dysplasias, and involvement of the cardiac and respiratory teams if needed. So I guess just to kind of summarize the overview of skeletal ciliopathies, this is a heterogeneous group of skeletal dysplasias. To date, there's 61 different types that have been described. Most of the severe conditions, the morbidity and mortality is usually due to the cardiopulmonary complications. The landscape has changed over time. So some of these conditions that we would always say, yes, this is perinatal lethal. Now that there are advances in neonatal care, more children are surviving that neonatal period. And then we're starting to see more of the extraskeletal complications becoming a bit more obvious when children are getting older. Pretty much all of the children do require some input from multidisciplinary teams. So having sort of a specialist skeletal dysplasia clinic where children can be seen can be helpful sometimes to kind of have an overview of all of the potential complications that might arise and then make appropriate referrals to all the different specialties that might need to input into that child's care. And then I think it's also important to mention that many of the classical ciliopathies that are not really considered to be skeletal ciliopathies do have skeletal features as well. So if we're thinking of, as we say, conditions like Bardet-Biedl syndrome, or many of the skeletal ciliopathies have postaxial polydactyly. So there are skeletal features with many of the ciliopathies. There are currently no interventional clinical trials for skeletal ciliopathies yet. So research and sort of interventional clinical trials, new therapies and new drugs is something that is happening at quite a fast pace in skeletal dysplasias in general. And there are now sort of gene-targeted therapies for some other skeletal dysplasias. At the moment, I think there's quite a lot of focus on achondroplasia, but things are kind of moving into other skeletal dysplasias as well. And so the hope is that at some point then there may be more kind of gene-targeted treatments for certain skeletal ciliopathies. But at the moment, the management remains supportive, surgical, if needed for those children with very small chests. And continuing research really to see when these clinical trials begin to move into disease-modifying therapies. So I don't think we're quite there yet. So that's all I've got to talk about this afternoon. So thank you very much for listening. I think it's a very broad group of conditions. So I tried to kind of give an overview and talk a little bit in depth about the more common types. But yes, it's a vast group of conditions. So I'd be happy to take any questions. Oh, sorry. And this flyer that I've put up here is just a meeting that is happening in November for anybody who's interested in hearing a bit more about the more severe types of skeletal dysplasia. So certainly this meeting, the Skeletal Dysplasia Group Autumn meeting, there will be talks on from presenters from across the globe talking about their experiences of looking after children with the very severe skeletal dysplasias. Okay, I will stop sharing.
Thank you very much, Rhoda. I don't think we've got any questions at the moment, but I've got a few. So you were talking about so a lot of these conditions can be picked up by antenatal scan at the antenatal scans, but as a parent whose children weren't picked up in antenatal scans because of their symptoms, but some people like with PCD have situs inversus and it can be picked up. I wondered what the process was for getting these children diagnosed, or what happens to the mum who's got told there's something wrong with her baby. Is there, are you talking to them, trying to give them tips and tricks on how to?
Yeah, so definitely, I think it varies in terms of what the condition is. So with the more severe conditions, those are the ones that are more likely to be picked up antenatally.
Yeah,
And for different reasons, it can vary who gets picked up antenatally and who doesn't. So some people might have an additional scan in the third trimester, for instance, but many of the more severe conditions, because you start to see signs at sort of 14 and 15 weeks, but everyone usually would have a 20-week scan, and so if it's not picked up on dating, we would expect there to be signs on the sort of at least on the 20-week scan. So at that point, we would expect the obstetric team to refer to the fetal medicine unit, and often the regional genetics team would become involved. And they would look at the images and sort of make a differential diagnosis, and some of the features that we've talked about might lead them to think, this could be a skeletal ciliopathy. Then I think the thought process would be, well, how severe is this? Is this something that looks like it's going to be very severe? And having that sort of conversation with parents, thinking about what they might encounter or expect when baby's born. whether they want to continue with this pregnancy, if this is something that is the baby will not, is very unlikely to survive. So I think that can be quite difficult. And I think it can also be very difficult to predict because, scans that the same scan that was looked at 20 years ago, we may have said this child is not going to survive. In
Yeah.
2025, that might be a different picture. But then what can help to give us more of an idea is confirming the diagnosis through genetic testing. And so it talked about the fact that when we're kind of around that 15 weeks, that's usually a time when it would be an amniocentesis, so putting in the needle in through the tummy, getting some of the amniotic fluid, and then doing a panel test for all of the different types of skeletal dysplasias, and that might pick up a diagnosis,
Okay.
and that might help the couple make that decision of what they wanted to do. For the more mild skeletal ciliopathies, it can be much trickier. So it may be that you might just see the extra digits and nothing more than that.
Yeah.
Uh, so again, it would be a conversation about whether you'd want to have a test in the pregnancy or whether you want to wait till baby's born and we can assess and maybe do some x-rays and then do the test after baby's born as well. Because the fewer signs that are seen antenatally, the harder it is to know what are we dealing with? Is this a skeletal ciliopathy? Is this another type of ciliopathy that just has a polydactyly? So it can be quite tricky.
Okay, thank you. I don't think we've got any other questions. And the only other question I had was, do you know how many children in the UK are affected by skeletal ciliopathies? I know it's a bit finger in the wind, but
It's
yeah,
a very difficult question to answer, actually. And I was thinking about this because in our clinic, we certainly have a number of children with, I would say, short rib thoracic dystrophy. So we have some children who have the diagnosis of Jeune, given the diagnosis of Jeune. We have other children who it's a different gene than the more common Jeune genes. And so it's called a short rib thoracic dystrophy caused by IFT, whatever the number is.
yeah,
The families like that. We don't have many children with Ellis Van Creveld in our clinic. I can't think of any actually that I've seen. So I wonder whether they are under more the sort of other services that might be treating the ectodermal problems, like dermatology, for instance, or
yeah,
so, and the cardiology with the heart defects. So I think sometimes if there's a specialist clinic, it is a bit easier to get an idea of how many children are out there or adults are out there with a specific type of condition. But I
yeah,
think lethal ciliopathies are so heterogeneous. It's such a big group of different conditions. Yeah, I think it certainly we look after about 250 children with different types of skeletal dysplasias if we exclude the achondroplasias, because that's
yeah.
another 250 on its own. And out of that, maybe 250, maybe I would say maybe 12, 15 of them have the skeletal ciliopathies that I've talked about. Um,
Okay.
at the moment, but there may be more. These are just ones that I can think of off the top of my head.
Okay.
It's really tricky.
So, but those ones that know that it's caused by cilia and they don't have a support group or whatever to help them, then the Ciliopathy Alliance want to make sure that they're not lost and that that if we ever get that magic bullet that says we can fix the cilia at root cause and it will fix all of these diseases, we want to make sure they're there for the party. And that's me being very hopeful and optimistic, but you never know. So yeah, but that's really interesting. Thank you very much. If nobody else got any more questions, then I will hand over to Matthew. So Matthew Carr is an experienced leader and project manager with a proven track record, public, private, education and voluntary sectors, but now he works for Retina UK. He leads loads of projects and he's done IT integration, strategic management, process management, and crime management. I'm sure there's an interesting story there, Matt. We could talk about that. And he's got a wealth of knowledge to manage and deliver a range of projects for Retina UK. But his database, I think, is one of his big projects at the moment for Retina UK. He's a huge advocate for eye health. I'm sure he might tell you why in his little chat, and promoting services that are available to individuals with sight loss and their families. So he's going to tell us a little bit about Retina UK and how being part of a support group is good for patients. Over to you, Matt. Is that okay?
Thank you, Dr. Fiona.
Thanks.
We've not talked about that bit yet.
Yeah, I haven't talked about
Yeah,
that bit yet. Yeah.
So yeah, thank you for having us along this afternoon. So my name is Matt Carr. I work for Retina UK. Been with the charity for 8 years. I've got lived experience of retinitis pigmentosa. So I'm kind of one of the many who have got a genetic diagnosis, but we're still waiting for really clever people to work out what they're going to kind of do about it and what can be done. So yeah, my background, I've been in the charity sector for since 2012 is when I came in. Prior to that, my background was in policing. Bizarrely, they kind of gave me a big, powerful car to drive and gave me guns and all sorts of things like that. So that certainly is another conversation for another time. But I was in the police service for just over 10 years in various places around the UK. But no, I'm now with Retina UK. So my role is the special projects lead. So I've got two areas that I work in. One is around policy and influence work. So we do a lot of work with the regulators, with government, and things like that. And then anything special project wise also falls within that. So as you said, we are in the process of looking at a clinical and patient registry for the IRD community. We're still very much in the early stages of that, but hoping to start collecting some live data next year. So once we're in a position to, we can certainly share a little bit more about that. So as I said, I've been with Retina UK for 8 years, and I've got inherited sight loss myself. And I know I am kind of quite biased, but Retina UK is a very special charity. It's also a special year for us as we mark our 50th anniversary. So half a century of supporting people affected by inherited sight loss, funding research and building a community that really understands what it means to live with these conditions. So today I want to take you through a bit of a journey. We'll look at how Retina UK has evolved over the years, the services we offer now, and most importantly, the role of peer support in helping people navigate life after a clinical diagnosis. I'll also be sharing some stats and some stories just to show how powerful that support can be. So for a bit of background, Retina UK is the only UK charity dedicated solely to supporting people affected by inherited sight loss. So that includes conditions like retinitis pigmentosa, Usher syndrome, Stargardt disease. There are a whole host of others that we are able to provide support for. Conditions are often progressive and for which there is currently no kind of cure or treatment, are one for a very, very, very small subset of people with this very, very specific gene. But these, whilst you've got the medical side of these conditions, it can be really, really daunting for people. What's often just as challenging is the emotional and the practical impacts of being told that you're going to lose your vision. And that's where Retina UK comes in. So over the past 50 years, we've been known as the British Retinitis Pigmentosa Society, the BRPS. That's how we started off. We then transitioned into RP Fighting Blindness, and now into Retina UK. We've been Retina UK for about 6 years now. And we've grown from a small, passionate group of individuals, all volunteered, into a national charity that offers a wide range of free services, and everything is completely free of charge. And everything we offer is accessible to anybody who needs it, whether it's a patient, the wider family, the support network, employers and professionals, even down to clinicians. It's entirely without cost. So just to give you a quick overview of what that includes. So firstly, we have our helpline. This has been going for almost as long as the charity. And only last year, we changed the operating model for how the service is run. But previously, it was staffed entirely by trained volunteers, all who have lived experience of sight loss. So they offer condition-specific information, signposting to benefits, employment, education support, and possibly most importantly, a listening ear. So the helpline is now answered by a member of the Retina UK staff team. And what we do is we triage the calls so we can ensure a consistent approach to information sharing, signposting, and really, really importantly, safeguarding. We've had a huge rise in safeguarding concerns since changing this model. So where necessary, we can then forward the calls onto one of our volunteers who have lived experience, as I said before, who can provide that peer support. So the volunteers have got a range of experience. We've got teachers, social workers, engineers, people who've got all sorts of experiences that they're able to share. Then there's our talk and support service. So this service has morphed and grown over the last few years. The service matches individuals with a volunteer for regular one-to-one peer support. This is quite often a lifeline for people who are feeling isolated and overwhelmed. Usually that's kind of done on a telephone basis. And we also run our local and online peer support groups, which I'll talk about a little bit more shortly.
Matt, can I just stop you for a second?
You
Someone
can.
just asked whether you were supposed to be showing a PowerPoint presentation, and I replied to say that no, probably not, because it's Retina UK and you normally just talk, but we wanted to check.
Yes, you are quite right. I don't like PowerPoints.
Okay.
They're inherently inaccessible to people. And because everything we do is accessible, I'm afraid you have to listen to me.
No, that's fine. It's just that I noticed that on Saturday because I went to the Retina UK conference and quite a lot of people didn't use them. And I was like, oh, why are they not using them? And so I'd worked it out, but I thought it was actually quite useful to ask you. So I'm sorry I had to stop you, but I thought it was important to ask. Thank you.
No, that's okay. That's all good. So Retina UK run an insight survey, and we do this every 3 years. We've just completed our third one. So in 2019, we asked our community if they knew what their genetic diagnosis was. And only a tiny, tiny percentage knew the name of their gene. And this was due in part to a lack of genetic testing, a lack of knowledge as to its importance. And as a result of this, we developed an online toolkit called Unlock Genetics. The toolkit helps people understand their diagnosis, inheritance patterns, and what it might mean for their family, as we provide, as well as providing resources for professionals to understand the importance of the patients having the test. So there was a significant block in GPs referring people on for genetic testing for various reasons. Following the pandemic, we held our second insight survey. So this was back in 2022. And we were concerned with the number of people who told us that their sight loss had an extreme or significant impact on their mental health. So as a result of that, we partnered with the mental health charity, the Arthur Ellis Trust, to develop the Discover Wellbeing Programme. This is an online course. It's structured. Program is designed to help people build emotional resilience. It's broken into 3 mini courses to build upon skills and look at when you're early in your sight loss journey. Then the next one, if there's any significant changes. And the third one is actually aimed at those who support people with sight loss, so from a professional perspective. And that was actually CPD accredited. So all of these modules include videos and exercises that can be done module to module. We also offer a volunteer-led support route for the courses too, if you're living with inherited sight loss. And of course, we have a fantastic information hub on our website, which has got loads of resources, articles, FAQs, research updates, as well as our quarterly magazine, Look Forward, which is available in all sorts of different formats for people. We host events and webinars throughout the year, including our annual conference and professionals conferences. As we just said, this year's conferences were literally last Friday, so a week ago today, and Saturday, and we welcomed just under 900 people across those 2 days. So the Fridays were for professionals, the Saturday was for people, our members, if you wish. And so whilst the charity offers so much information and support, we're also really deeply involved in supporting medical research as well. So to date, we've invested over £2 million into this area, and we're hoping to, we have a challenge to do £1 million in this coming year as well. So that's going to be a massive investment into research into these conditions. And whilst we're doing this, we're also keeping our community informed about the latest developments and to invite them to participate in studies and trials and things. And finally, we are actively engaged in the influence work with government and medical regulators. As I said before, this is my area, ensuring the needs of the community are heard and incorporated into policy and wider decision making. So things like the PIP debacle, shall we say, from a couple of months ago. There's a one around transport, which is ongoing as well at the moment. So a lot of policy work is happening there. So this is done either directly or through collaborations with other groups in the sector, such as the Ciliopathy Alliance. So all of this is designed to support people not just at the point of diagnosis, but at any point throughout their journey with sight loss. It's a life cycle rather than a one point of impact. So let's talk about our peer support, because this is where the magic really happens. When someone receives a diagnosis of inherited sight loss, it can be an absolutely life-altering moment. I remember my mum was a little bit more different to others, but it's one of those moments that you never, ever really forget. Or if you're a parent of a young child being diagnosed, it's absolutely devastating news. There's often a flood of emotions: shock, fear, confusion, grief. And whilst the medical professionals can explain the science, what many people really need is to talk to someone who's been there, someone who actually really gets it. So that's where our peer support network comes in. And this is something we do really, really well. So we've currently got 16 local peer support groups across the UK. We've got another one launching very soon in Dorset and in the Southwest. So these groups meet either online or in person, and they offer a nice, warm, welcoming space where people can share their experiences, ask questions, get advice, and build lasting relationships. As I said, this is all peer support led, not necessarily by staff members at Retina UK, but people who are actually living with the conditions. We know that not everyone can attend in-person meetings, so we also have 11 online and special focus interest groups. So these include women's peer support, men's peer support. We've got a young adults group and a parent and carers peer support group. More of a general one is our national peer support group. So this anybody can join at any time. We have groups specifically for Scotland and in Wales. And we also have a talking series around home and garden, creative arts, travel and technology. So those are really, really popular groups. So the Talking Tech group, for example, so that launched in March 23 with 120 people joining that first meeting, and the meetings have continued to grow. The Talking Travel launched in February last year, 24, 80 people. The women's group, which started in March this year, had a huge 65 registrations. And this group was spoken about by one of our panelists over the weekend. And this person is a social media influencer. She has some fantastic followings online. But she said she'd never actually spoken to another woman with her condition. And that was a really, really emotional time for her. We've grown these groups, and the growth has been phenomenal. So 2022, when we rejigged the groups, we had 575 people attend across all of the peer support groups. In 2023, that jumped to 933. 24, 1,139. And this year, 25, we're only, three quarters of the way through the year, and we've already had 1,046 people attend all these groups. So the numbers are growing year on year on year, which is absolutely fantastic. So these numbers, they all tell a story. They show that people, they're hungry for connection. They want to talk, to listen, to feel understood. And they want to do it in a space where they don't have to explain what it's like to live with one of these conditions, because everyone else just gets it. So I mentioned our talk and support program. So this is where we offer one-to-one support. So the program is especially valuable for people who are newly diagnosed. They might not be ready to speak to people in a group setting. So it's a much more private, personal way to connect with people. So right now we've got 41 active service users in the programme, and over the past 5 years we've supported an additional 59 people through this service. So the model is simple. We match each person with a trained volunteer who has lived experience of inherited sight loss. We match them based on age, condition, personal experiences, gender, religion. There are a number of ways we can do this. And once both people have matched, and it's a little bit like online dating, really, but it's not dating at all. That is very, very absolutely off the chart. We don't do that. But once both people are comfortable, they simply arrange their own contact, usually by phone, but it can be by email or whatever means works best for them. And they build that relationship based on empathy, trust, and that shared understanding. So it's not counselling, it's not advice giving, it's just one human being saying to another, you're not alone, I get it. So why does all of this matter? So because inherited sight loss isn't just medical, it's a life experience. And whilst clinical care is essential, emotional and social support are just as important. The peer support helps people feel less alone, to gain confidence, to learn practical coping strategies, and to see a future beyond their diagnosis. It helps people move from the why me to what now, and to do it with hope, with community, with dignity. And for many, it's the first time they've felt truly seen and heard. Now, before I finish, I just want to read a letter that we received recently from a member of our community. And he describes the impact one particular Retina UK volunteer made through peer support. And I've got to try not to do this with a really, really strong Welsh accent. So the letter reads, so my name is Robert, or Bobby, as people call me, and I'm writing to you personally to thank a member of your team who, for someone I've not met, has been the pillar of support as I undergo medical investigation for onset symptoms of retinitis pigmentosa at 32 years of age. I found your helpline when I slipped into a very dark place, and after months of persistent encouragement from my ever-supporting partner, I decided to ask for help. The person who I was in contact with was Mark Baxter, who was diagnosed with the same condition, and I'm currently being investigated for. At this point, I thought talking with a stranger I've never seen face-to-face would never help me in the slightest. I'm a serving prison officer, and I live and breathe my career. I'm proud of what I've achieved. I'm an independent man with a driving licence and a recently bought home. With the onset symptoms of retinitis pigmentosa, I've blagged my last 2 years since developing issues and bottled the thought of myself ever having this condition. I lied to family, friends, and hid it very well, especially through work. I was scared and in doubt the service would keep me on, and the thought of losing my independence, especially with driving, mentally impacted me. My night blindness is poor, and although my central vision is healthy, my peripheral has gotten worse over the last 2 years, where I feel glasses no longer make any difference. RP runs strong in my family as it affects my mother, sister, aunts, uncles, and cousins. The stigma of growing up in my family was I was never educated on RP and believed never to be affected by this condition. Being a prison officer, especially within the last 2 years, has been the most difficult career I've undertaken. The job needs healthy vision, and with the long hours and constant pressure of dealing with the most violent and challenging people, have taken its toll, not only physically, but mentally. I started to fear the winter season due to the short lighting hours and long hours of darkness. My mind became a minefield, and I kept this a complete secret, putting my partner under a lot of stress, and felt I became a burden to her. I've been assaulted 7 times in the space of 1 year. The mental load it had on me weighed me down. I fell into a very dark place as RP was the main factor for the stress, fear, and doubt clouding my mind and dragging me further and further down a horrible path. RP was the ball and chain holding me back, and not knowing was certainly slowly killing me. Mark, who at the time was a complete stranger, gave me hours of his time to let me vent, to air my fears, frustration, and emotional burden. Those hours changed my mindset. Not a complete 180-degree change, but enough to take a step forward. A step forward to seek advice from my GP, which led to being referred to Oxford for genetic testing, and having the confidence to be honest with my employer. Mark pushed me in the right direction, and it's usually me who's the one picking people up and pointing them in the right direction. Mark stated my visual impairment is not weakness, and I should have every confidence in myself that I will get through this journey. I've received a vast amount of support from my employer, friends, and family since I've decided to be responsible for my own health and mental health. I've chosen to no longer drive until I get back official results and answers. I'm undergoing genetic testing. I'm restricted until further notice with work, but assured I will get full backing and support, whatever the outcome may be with my vision. And Mark played a factor in this. His knowledge, advice, and firm truths made me realise I should be pursuing this, made me feel optimistic, and it's the right thing to do. I'm now able to talk openly and honestly. I feel better for it. I want to thank you personally for your organisation, your charity, your colleagues, and as a whole, everyone who is involved with Retina UK. I will continue to seek support in my darkest days to come and openly talk on my struggles and not be afraid of change. I've set some goals to help me along my journey. Although I still struggle to come to terms with a lot of stress that comes with this, I look forward to the future and making the most of what I have left of my vision. Your team of volunteers are lifesavers and made a massive difference with only just being a phone call away. I no longer feel alone, and I've been inspired to go out there and prove my potential condition could not impact my life for the worse. I hope you enjoyed this read, and I sincerely thank you. I hope others reach out to your amazing team. It really works, and I'm glad I made the decision to reach out. Kindest regards, Bobby. So, as we mark 50 years of Retina UK, we're not just looking back, we're looking forward. We're building a future where no one faces inherited sight loss alone, where support is always available, where people can connect, learn, and thrive. So if you're a charity professional, I encourage you to think about how peer support could enhance your own services. It doesn't have to be complicated, it just has to be human. So thank you very much for listening. I hope it's given you a bit of a deeper insight into the work we do here at Retina UK and the incredible impact of peer support. Thank you.
Thanks, Matt. That's very brave of Bobby to write that letter, isn't it? Yeah, as we know, in my family, we're two people with RP and possibly a third, and it's really interesting. We have got some questions. Tonya said she might have missed it, but when you've got different groups, you said, are they online, in person, and both? I think you said they were both.
Yeah, they are both. So the way the peer support groups run, so it depends group on group. So some will meet on a monthly basis, some might only meet once a year. So they may do a combination, and some of them meet face to face, and over the winter they may meet online. So it's very much depends on the group and where they are.
Okay, and then just do you limit the numbers in each meeting?
No.
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 Okay. Right. Yeah, I got one random question because you said that it wasn't a dating thing, but have you had any marriages yet from your peer support groups, peer to peer?
Not internally. No. No. There are a couple of couples who volunteer. We have a lot of couples who kind of volunteer.
Yeah.
But no marriages out of it
No
yet.
marriages yet.
No.
That'll be good. There'll be lots of good if there was, then all the wedding presents could go to the Retina UK instead of wedding presents.
That sounds like a great idea. We should do that as a fundraiser.
We should be pushing that.
Yeah.
Well, Rhoda, have you got any questions?
I do. I for some reason I can't use the chat. I don't know.
Okay.
I can only read them. I can't type a question, but I did have a question, Matt. Thank you so much. It was really powerful just hearing that letter. And in genetics, quite a few families sometimes we're diagnosing RP for the first time, Usher syndrome for the first time in a very young child. And parents, as you said, it is very devastating for them. And I was just thinking about the peer support group for parents, with a new diagnosis. Is that something that you do as well, sort of other families or?
Yeah, absolutely. So we have the peer support group for parents. So one thing we don't do as a charity is directly support young people. And there are a number of reasons for that. And the main one is there are some charities out there who do it fantastically, and they've been doing it for a number of years. So, look, Vista, for example, they're specialists in that area, and they all obviously look, for example, have peer mentoring for young people. So there's no way we could replicate that. So we concentrate predominantly on the adults than we do the young people.
Okay, thank you.
Anybody else got any other questions? No, I don't think so. Thank you so much, Matt. That was really interesting. Thank you. Right, then I think it's my turn now. You did it all so seamlessly, and I'm probably not going to be so cool. Right, can everybody see my screen?
Yep.
Yeah, thanks.
It's not in slideshow.
No, there we go, slideshow. There we go. Right, so I have told you who I am, Dr. Fiona Copeland, as of last week. So yeah, I'm just going to tell you a little bit about the Ciliopathy Alliance and try and top and tail those great presentations. So oh, sorry. Yeah. So hopefully, yes, now you've got a better understanding of the importance of genetic diagnosis, because you can get access to great support. And we want to make sure that all patients with ciliopathies, regardless of whether they have a patient group or not, are able to benefit from the great work that our clinicians and researchers are doing to improve their lives. So I hope I can shed a bit of light now on how we can help those patients. So we have a new strategy, and we've been strengthening our governance. We have a proper financial plan to allow us to grow and be sustainable. And we want to be able to support our ciliopathy community by providing more information on our website about research, how to get involved, and have more information on ciliopathies, on the clinical trials and how to take part in them. And we also want to increase the number of clinicians and researchers we're involved in, and then setting up events for our members to share ideas and best practices. So if you want to know the details on our new strategy, then please contact us and we can help give you a bit more information. But basically our vision is that we really want a world where individuals with ciliopathies receive timely diagnosis, they're effective for treatment, and an improved quality of life. And our mission really is to unite and empower patients and families and healthcare professionals, researchers, patient organisations to advance the understanding of research, treatment and advocacy for ciliopathies. And we have loads of patient groups already. We have a number of charities already working with us, and we're providing support networks. And we also provide them support networks for each other. We share best practices and our achievements and our social medias. And you know, like Retina UK have got all these great peer support meetings, and I'm sure if the other charities involved with ciliopathies wanted more details on how they physically run, then Matt and his team would be more than happy to help with how to set them up and how the logistics work, so that we don't have to reinvent the wheel. But the world in rare diseases is changing, and some of these groups like Retina UK are well established and thriving, and some are still working with volunteer staff and they're only advocacy groups for a very small number of patients. Juba and Jeune, for example, have support groups, but they're not really well established. So our plans are to engage with those ciliopathy communities that are not so established and see if we can signpost them to resources and share resources and experiences as best we can. And as a starter, we've identified that skeletal ciliopathies are not represented in our communications medical board, and we need to help address that issue. One of the reasons we've got Rhoda on our trustees as a trustee. So we have this ambitious new strategy which includes all of this. So please watch this space. So we really need your help. So if you haven't joined the Ciliopathy Alliance, then please do, with my great QR code. It took me ages to work out how to do that. If you join the Ciliopathy Alliance, you are legally allowed to vote on important matters at our annual general meeting. But we can please signpost patients, clinicians and researchers interested in ciliopathies to us. Get involved in our patient public events off to speak at our webinars, review content for our website, talk to us about conferences or at conferences, and ask us for funding or to help collaborate with your funding. So we need help, we need volunteers on a regular basis. So please contact us if you think you can help us in any of those ways, or if there's something that you think we should be doing that we're not doing, then please get in contact. We'd love to hear from you. So I haven't got anything else to say. Has anybody else got anything? Matt, are you finished?
Yes, I have nothing else to add.
Okie
Other than
dokie.
thank you for having me.
Oh, thank you. Has anybody got any other questions? We've got any questions open. Tonya, have you got anything else to say? Because you're the only one that were allowed to speak.
I'm forgetting that I can be heard. Yes, nothing more from me, but just a big thank you, Fiona. You've done an excellent job as always, and thank you to the speakers. It's been really interesting.
Yeah, thank you very much for your time, everybody. Thank you, Matthew and Rhoda. I hope you all have a good weekend, and hopefully we'll see you at the next one. Thank you very much. Take care, everybody.
Brilliant. Thank you.
Thank you.
Bye.
Thanks. Bye.